So I'll talk a little about what we're doing on the international side of things. Hopkins is involved on domestic telemedicine. It's a challenge for our organization, just as for many organizations. Really the three big barriers are reimbursement, followed by reimbursement, and finally reimbursement. So the nice thing about international, it's the Wild West. And you can do a lot more and a lot more of the outreach and not have to worry about this because, number one, you're going after a market population which is willing to pay, also known as reimburse, for the services, which makes it easier. Mostly you all are techie people, and for this stuff it's easy, throw some boxes, get up and running, technology and you're hooked up. I'll share some of the things that I've learned along the way. So when you're dealing with your clients and others around what really goes on, you'll have a new perspective of the things we deal with every day. They make me say this at Johns Hopkins. We're a small hospital, been around for about 125 years. If I don't say this, they shoot me when I go back. We've been ranked #1 according to US News for 20 years in a row. It really doesn't mean much, but they like for me to say that. Primarily, we're a $2.25 billion integrated health system. Our footprint's actually been growing a lot in the US over the past 18 months. Our biggest thing is research. Research. We actually receive the most NIH grant funding in the country. It's really been some of our great areas of innovation. But our global presence has been expanding and has been for about 10 years. I've been actually a part of Johns Hopkins International for this period of growth. We actually, many years ago, made a decision to start expanding our presence globally. Number one, we have international patients that came to Johns Hopkins. We see about 3,500 international patients a year that travel to Baltimore. But we started reaching out to organizations globally. We manage 3 hospitals in the UAE for the UAE government. We also manage a small private hospital in Panama. We have affiliations in Canada, Chile, Istanbul, Turkey. We're in Japan. We're doing new collaboration around education in Malaysia. So there's a lot of outreach right now. And so the idea is how do we kind of share that? And the challenge that I get tailored with each and every day is how do we share our knowledge and expertise effectively, efficiently, and economically. One thing about what we do in the telemedicine space is that we don't ever try to say that we will eliminate the physician to patient interaction. I don't want to do that at all. In fact, I don't believe in that. But what I do believe is that we are going to try to fill in the gaps. We're the people in between the visits. We're the people that can be engaging during that period of time. So at Hopkins, we've got a couple international programs. We have our second opinion service. We receive about 700 cases a year that we process. This is what we call in the business store and forward. So international patients or their physicians will send us their cases from around the world, their medical history. We have a web-based system, which this is loaded to sometimes. We also use a very fancy telemedicine program, a technology called FedEx and DHL that send us records from all over the world and gets to us as well. In addition, our televideo conferencing program has been growing. We'll do about 300 events a year. These are mostly educational based for the most part. We also do department grand rounds that are sent to our international affiliates, as well as run a virtual tumor board on a regular basis. So our physicians here are having a live video program with hospitals around the world and doing a tumor board presentation. What was interesting is what started as we're going to push to you an interesting case is now turning into we want to hear from you about what is an interesting case. So it's creating this network, which I'll talk a little bit about here in a minute. So some of the benefits to the international community, it's pretty obvious, but it's a good reminder. Number one, improve the in-country healthcare. That's our goal. We can't see every single patient here in the US. I'm sure UPMC says, hey, we've got a limit to the number of cases that you can handle. We have the same challenges as well. But where we can, our organizations really can help is for those challenging cases that they can't handle locally. But we want to try to make better physicians around the world. We want to try to help that process. We don't want to just bring everything back to the US. We don't have the sustainability for something like that. In addition, we want to support these local clinicians with their knowledge. They've got a challenging patient. We don't want them to feel like they're on their own, so to speak. So we kind of want to give them that accessibility to information that they can handle these cases locally. Knowledge transfer is a term we use around Hopkins a lot. It's our doctors traveling around the world for these educational programs. What I feel is that what we're trying to do here with our virtual space is really be synergistic with that. Again, I don't want to take away from these large trips going around the world to speak at various programs or do cases right there as an education format. But when they do come back, what do we do for the next 51 weeks before they go back next year to do the same kind of program? And so that's what we're trying to do with our outreach. Clearly, things are changing quickly in the healthcare sector, whether it's the research that we're putting into place, the innovation that's coming out of the academic medical centers out of the US, and how we can share that. So we want to share that knowledge and put it into place. We want to decrease our costs, increase our resource utilization. Same challenges here, whether you're going from here, whether you're going from Baltimore to the UAE, or whether you're going from Pittsburgh to Johnstown on the other side of the mountain, we're looking at resource utilization, which is a challenge. I think also telemedicine can really try to push how we typically do things and how we've been doing it in the past. And I think what we're trying to do is introduce these technologies, make them easy to use, a very simple user interface, which is important, and really try to create that innovative approach to how do we handle this population. Challenges, as we all face them every single day. Number one is acceptance by physicians, and I think that one, yeah, it was probably at the top of my list a few years ago. Maybe it might be number 2 or number 3 on my list now. I think acceptance is really starting to come around. I think people are really starting to engage with these technologies. I think more and more people are using these technologies in other aspects, just like what was presented earlier. We're using e-commerce, we're using e-banking, et cetera. Well, now we're going to start being more comfortable with using this for other ways of technology in healthcare. IT departments, the idea of setting up these systems that connect to one another, whether it's the big brother attitude of the outsiders trying to hook up with other ones, whether it's the local, when I'm dealing with a hospital in the UAE and their bandwidth is very limited for the entire hospital. And now they want to say that they want to run an HD video conference, which has significant bandwidth requirements. You've got some challenges there as well. Procurement process, that's an interesting one on the international side of things. How we do things here in the US is very, very different than how that might be done overseas. In the UAE, for example, I had the experience where our hospital there wanted to purchase a video conference unit. Hopkins we've standardized around the Polycom platform. So I was encouraging them to get a Polycom, and then we can make sure that things are running up and smoothly together. Well, the process there has to be is you have to put it in the newspaper. You have to post this procurement announcement in the newspaper. It's got to sit there for a week or two. Then vendors from around have to submit proposals to the governmental organization, who then looks at it, not knowing anything else about what has to go on. And then they go with lowest bid. And lowest bid isn't necessarily what you were trying to help achieve. And I see a lot of people nodding their heads around here. So it's a challenge learning about this procurement process. Reimbursement clearly is one that will, everyone talks about over and over again. Reliability of equipment actually has gotten a lot better. But what's been interesting is the management of that equipment on the far side has been a challenge. So I do video conferences all over with all our hospitals around the world. But now I'm trying to use some of the new infrastructure that Hopkins has put in place to do more multi-bridge calling, things like that. We put on a whole new infrastructure. Well, everyone's running software that's 3 or 4 versions old. They're out of warranty, and so and they don't know because they're not familiar with it. Like I'm sort of the expert for them. So that's one thing I've learned really in the past 6 months is this. The equipment works, but they're not able to take full advantage of it because they're not staying up to date with all the softwares, et cetera.